Okay, so I think we can start. Good afternoon, everybody, and welcome to the next webinar by the EANS Young Neurosurgeons Committee. We are very happy to announce that this webinar is sponsored by Gottman Integra, and the topic of the webinar today is dural closure, how I do it. So we have some experts who are going to talk about it, and afterwards, as usual, we are going to have the roundtable where we will talk about different ways how to do it, and of course discuss your questions. So please mind the housekeeping rules. We have the Q&A box where you can write your questions, and we're going to try to answer them during the presentations or at the end during the roundtable. So first of all, I would like to welcome Felicia Esposito, who is going to talk about a quick overview on ways of dural patches and duroplasty. Please, Felicia, show us your presentation. Thank you. You have to unmute yourself, sorry.
Okay, thank you very much. By the way, I wish to thank all of you because this is the Young Committee of EANS. So you included me in the young, among the youngs, and I still feel young. So thank you very much for this. Let's just share my presentation. Okay. So I will go over on general characteristics of dural closure, and with some points on the difficulties in dural closure in spine surgery, posterior fossa surgery, and endoscopic endonasal surgery that will be covered by the other speakers. And just to break the ice and start with the general themes, I hope I will not be too much general and too much basic, but I wish to break the ice with this joke, I would say. I don't know how many of us will recognize this building. I don't think too many, but I guess now more people will recognize the Sistine Chapel in Rome. It's the ceiling and one of the walls of the Sistine Chapel painted by Michelangelo. Why I'm showing this in this presentation on dural closure? Because this may be one of the most famous frescoes in the ceiling of the Sistine Chapel. And if we consider the figure of God, we may see that Michelangelo painted the figure of God with this mantle, this coat, I would say, and it is the shape of a brain. So Michelangelo wanted to paint the idea of the God with by painting his coat, his mantle, and that's why I showed this, because the mantle of the brain is actually the dura mater. And we have to keep in mind that the dura mater is not a unique thing in human body, because all other many other organs have this mantle, this protection. The lungs, the heart with the pericardium, the abdominal organs with the peritoneum. Keeping on the general things, I was curious why it is called dura mater, which in English is hard matter. It is because it was a wrong translation from Arab to Latin, because in Arab it was called I'm sorry for my pronounce, al-dimag, which is al-dimag means something like envelope. something like blanket, or on the other side, it means also the one who feeds. So it was translated in Latin as mother, which is mother. But actually, the actual meaning was the hard blanket, the hard cover, the hard membrane enveloping the brain. And the functions of the dura mater, as I'm sure every one of us knows, know these function. It contains, it isolates, it protects, and feeds like a mother, actually. And every time when the integrity of the dura mater is lost, all these functions are lost as well. And there are, every one of us know that there are several possibilities in which the continuity and the integrity of the dura mater is lost in trauma, like in these cases. Penetrating and non-penetrating injuries may cause a dural opening. By the way, these are my first two wives. My first wife and my second wife. Actually, I'm just joking. So trauma may cause a dural opening. Tumor, like in this case of recurrent glioblastoma, may cause a preoperative opening of the dura mater. There are several possible congenital abnormalities, like this encephalommeningocele or this myelomeningocele that cause a defect in the dura mater that need to be repaired in some way. Of course, most of our neurosurgical operations are done with the planned dural opening, either in cranial surgery and spine surgery. So in all the when every time we need a plastic extension of the dura mater, like in this case of decompressive hemicraniectomy or chiari surgery for chiari malformation and so on, or we may face some not incidental durotomy during spine surgery. I'm sure that this will be discussed in the next presentations. So every time we have a dural opening, we have to close it to reestablish the continuity and the integrity of the dura mater, because if it is not, there is a not effective, ineffective closure of the dura mater, as every one of us know, that we have several possible complications. Pseudomeningocele, like in posterior first surgery, hypertensive pneumocephalus, infections, prolonged hospitalization, and so on. So closing the dura mater, like Harvey Cushing said 100 years ago, more than 100 years ago, should be done painstakingly. So also because we have to consider that there are also economical costs of this possible problem of ineffective closure of the dura mater, and also we may face medical claims, medical malpractice claims following a not effective closure of the dura mater. There are some risk factors, either preoperative and intraoperative risk factors that may cause a more difficult closure of the dura mater. If it is a recurrent surgery, if the patient had the prior radiation therapy, if the patient had a prior long-term corticosteroid therapy, and so on. And there are also some chronic conditions that may cause an increased risk of postoperative CSF leak due to an ineffective dural closure, like thrombocytopenia, again, chronic corticosteroid therapy, and so on. Also, all the age is a risk factor for postoperative CSF leak. Obesity, I'm obese, so I know that if I had a neurosurgical operation, I was at higher risk for postoperative CSF leak. Long and complex neurosurgical procedures may increase the risk for postoperative CSF leak, and so we have to close the dura. This can be done by primary suturing the dura, using different graft tissue for duraplasty, and use surgical glues as sealants. Only one of these methods, all these methods together, two of these three methods, either in Europe and in North America, there were some surveys that favored the use of multiple strategies for dural matter reconstructions, especially in skull base and especially in spine surgery. And also we had an Italian survey that was the results were in line with the two German and Canadian surveys. So primary suture of the dura mater, we have to watertight close the dura mater, or we may not have a watertight closure of the dura mater. This is still a matter of debate, because there is no clear evidence that watertight closure of the dura mater is more effective than no watertight closure of the dura mater. There are some studies favoring the watertight closure, and some studies of the same importance favoring, not favoring, but not against a not watertight closure of the dura mater. If we had to primary suture the dura mater, what technique we have to use? Interrupted suture, running lock sutures. There are some studies that favor and that show that running locked suture is better than simple interrupted suture, and all other studies that show that the smaller suture is, the better the results are. Every time we cannot primary suture the dura mater because the gap is too large, or we have to use something to expand the durotomy, we have to close some graft tissues, different kind of graft tissue, and we have several different possibilities: autologous materials, homologous materials, heterologous materials, synthetic, either resorbable and not resorbable materials. Unfortunately, the ideal dural substitute for duraplasty does not exist so far, because the material should have all these features, all these characteristics, and so far no single dural graft or dural substitute has all these features together. We may use autologous from the patient, tissues from the autologous, and we use currently the galea capitis, the fascia from the temporalis muscle, the fascia lata, fat, and so on. and all these materials are of course at the highest biocompatibility, but on the other side we have the cons that we cannot harvest as much material as we may need, and we need a second incision, a second operation with the prolonged surgical times, and some scars may be aesthetically disfiguring. So they are not for free. I would mean they are not for free, even though we may think that they are free because we can harvest from the patient itself. We may have the possibility to use homologous from cadavers, substitutes, but on the other, we have to consider that in some countries we may have ethical problems with using cadaveric tissue, or we may have a slightly higher risk for infectious disease, transmission of infectious disease, like the Creutzfeldt-Jakob and so on. We have different possibilities in using heterologous dural substitutes from animals, pericardium, the bovine pericardium, the bovine collagen-derived grafts, or equine collagen derived grafts, and they have a low antigenicity. They are dynamic tissues. I mean that they promote neodura formation. They are highly available because we may use more than one different grafts. And on the other side, there are some theoretical risks of zoonosis transmission. And we have different possibilities in using synthetic substitutes, either resorbable and non-resorbable. No one, I repeat, no one is ideal. Some of them are good, some of them are bad, some of them are ugly. No one is the perfect. Then we may use different surgical glues, either even from the patient itself with the autologous fibrin glue, or heterologous fibrin glue like T-Seal and so on, or synthetic surgical glues that may help in sealing the defect, and also like in transsphenoidal surgery or posterior fossa surgery, they may help in holding the reconstruction in place. Like, I will skip this. This is the autologous fibrin sealants. So the fibrin sealants may have all these three possible advantages. I mean, they may help in obtaining a watertight closure. They help holding in place the other materials used for reconstruction, and fibrin-based sealants may also have some bleeding control capabilities. I'm sure every one of us use fibrin glue with the Surgicel. No, this is a common combination used in neurosurgery. We have to remember that the two things together should not be used. Every one of us use this, but the two things together should not be used because the Surgicel and the Tabotamp and things like this have a low pH, and that may cause some problem in the effectiveness of the surgical glues, like fibrin glue. So every one of us use this.
I'm very sorry to interrupt you, Felice, but can you speed up a little bit because we have three more speakers? Okay. I'm sorry.
I will speed up because this 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 part, I'm sure that Diego will cover this. So in spine surgery, posterior fossa surgery, and endoscopic endonasal surgery, why the reconstruction is something difficult to achieve? Because while in supratentorial and the supratentorial space, we repair the roof from above, which is a little bit easier. From below, in endonasal surgery, in posterior fossa surgery, we have to face some additional problems like the brain pulsation and the gravity. No, so in these cases we have to use some basic concepts. So fill, reestablish, hold, and seal. Fill that space, reestablish the continuum of the dura by using different grafts. Hold the reconstruction in place to avoid that the gravity, with the gravity, the reconstruction will fall down, and use the tissue glues to seal if necessary. I will skip this. We already did say this, but one of the things we use, one of the tips we use in the OR is to ask after the reconstruction, we ask the anesthesiologist to increase the intrathoracic pressure by using the Marsaba maneuver to check the effectiveness of the dural closure when we are still in the OR. And what we do after, if we have still a postoperative CSF leak for an inadequate dural closure. In case of minor CSF leak, either in endonasal surgery and posterior fossa surgery, we use a repeated injection of fibrin glues still in the ward, not in the OR, and the same concept of the epidural blood patch. Now, the epidural blood patch sometimes, most of the times, help us to stop small leakings. And with this concept, we use, by having in mind this concept, we use fibrin glue to fill the dead space and seal, either in posterior fossa surgery to treat this pseudo-meningocele of the posterior fossa, or in spine surgery, like in this case. All these are our cases in which we stopped the leakage by injecting fibrin glue in the epidural space, and of course in endoscopic surgery. The video will not play, but no problem, because Diego will go over these aspects. And most of the times, in case of minor leaks, in minor problems, we may avoid a second operation. A second operation, which is always painful when they are our reoperation, but they may be fun if we have to operate the complications of another surgery or surgeon. And this was my last slide.
Thank you very much, Felicia. And for time's sake, I would like to go to the next talk by Diego Macenta on endoscopic dural closure. So please, Diego, show us your slides. Thank you.
Okay. Do you see my presentation?
Yeah.
Yes, we can see it.
Okay. Thank you for your kind invitation, and nothing to disclose. This is our algorithm for endoscopic skull base reconstruction in case of a CFS lake and in case of there are no CFS lake. Don't forget the skull base reconstruction is most important also in case of an extended approach when the internal carotid artery is naked in the sphenoidal sinus. But this talk is about CFS lake. It's the most important to know the dimension of the defect, the type of pathology, and localization. In case of the anterior cranial fossa, we use the mucoperiosteum graft of the middle turbinate, but in case of the larger defect, we use also the multilayer. In case of the CFS lake in the sellar parasellar region, we use the intracellular fat, and we combined the intracellular fat with the mucoperiosteum or pedicle flap. Don't worry, case by case, I will show you in case we use the pedicle, not pedicle flap. The big problem are in case of the supradiaphragmatic transplanus transtuberculum approach. In this case, very complex, we use the multi-layer gasket seal with or without a pedicle flap of nasal septum. In case of transclavial approach, we use the multi-layer flap with or without pedicle flap. The post-operative manage in our department is we perform always the CT scan in case of the extended approach to check the pneumocephalus and evaluate in case of the intracranial bleeding, obviously. The patient's bed rest is prescribed for 3 days. Cough mixtures and laxative are prescribed. We don't use the spinal drainage. The lumbar drainage we abandon because it could be, in our experience, could be more dangerous than the defect itself. First step, intracellular CSF leaks. In case we are very, very little small defect, very, very little hole in the diaphragm or cistern, supradiaphragmatic cistern, it's enough to put inside the fat, abdominal fat, and cover with the only mucosa of the sphenoidal sinus. When you started the procedure, preserve the mucosa of sphenoidal sinus and don't remove always. The mucosa is a really effective tissue to close a small defect. In case of, in the right side, you see a large defect. In this case, you can see the supracellular space with the optic chiasm. We use the abdominal fat and we cover with using the middle turbinate or mucoperiosteum of the middle turbinate. We don't abuse of the pedicle flap, as you can see. This is a case of a small defect. This is the macroadenoma with the partial invasion of cavernous sinus. We skip to after the tumor removal. During the exploration, we observe a little defect in the supracellular space. As you can see, this is the optic nerve, and this is the carotid artery. And you can see also the CF lake. In this case, we choose to use the mucoperiosteum of the middle turbinate, and the use of the middle turbinate is a very low mobility procedure. We put inside the fat in our surgical field, and after we cover, also we use also the heterologous material, the biodesign, but the principle, this is a mechanic system to pull out the fat, and after we close with a free flap and not pedicle flap. In case of a large defect, such in this case, with a large pituitary adenoma with the invasion of the third ventricle, we skip our procedure using also the pedicle flap. The first layer is, this is the heterologous material. We abandon the fascia latas because the patient complain a lot, the pain after the graft. And we use the first level intradurally. This is heterologous material named biodesign. After we fill the surgical field with the fat, second level of heterologous material, gasket seal, this is the piece of bone, and finally, we use, in this case with a large defect, closing the third ventricle surgery, the pedicle flap of the nasal septum. And this is, you can see the post-operative results, radical removal, you can see the fat, and you can see the pedicle flap using to close. Transcribiform approach. In this case, the transcribiform approach is used for example, a lesion located in anterior skull base fossa, for example, in intra-extradural meningiomas. And you can see the gyrus rectus, and we prepare the large defect using, in this case, this is the tabotan, using the heterologous material intradurally. Second layer extradurally between the dura madre and the bone. I'm sorry. We filled all the little space with the fat, piece of bone to control the pressure of the intracranial pressure can be displaced, all the structure of reconstruction. Well, glue, it's not mandatory, but it's very effective to maintain the graft in position. And finally, in this case, we place the double pedicle flap to control our closure. In case of combined transcranial transnasal transcribiform approach, for example, in this case, you can see the neurosurgeon uses the microscope, but you can see also the exoscope, and the anti-surgeon use the endoscope. We prepare intranasally. This is the tumor removal phase. It's not the hem of this stalk. In this case, you can see the double. We operate simultaneously the neurosurgeon and the surgeon. The neurosurgeon suture the dura madre with using the Gallia flap as usual. Oh, I'm sorry. I would like to show you. As you can see, it's most important to suture the graft of Gallia with the dura madre of anterior skull base. We control transnasally the effectiveness of our closure, but in this case, there are no nasal tissue to control. So in this case, the surgeon is alone during this type of closure. In case of the tumor permit to use the pedicle flap of nasal septum, we can use also the pedicle flap intranasally. This is the small craniotomy frontal. It's not enough to open widely. It's enough 2-3 centimeters, no more, with only burr hole, as you can see, to prelevate the fascia, the Gallia, sorry. In case of the supradiaphragmatic approach or tumor located in the third ventricle, this is a case of a craniopharyngiomas located posteriorly to chiasm. This is the A1A2 complex. This is the third ventricle, massa intermedia. We use the multi-layer gasket seal. We fill the fat in our surgical field. In this case, this old move clip, we use the fascia lata. We put the piece of bone to contrast the pressure. And finally, we put the pedicle flap of nasal septum. When the pedicle flaps are mandatory, obviously in the large defect with enlargement of the optic channel, for example, in tuberculum cella meningiomas, because during this procedure, when we choose to use the endoscopic endonasal approach, we open widely also the optic channel to remove intradurally the remnant of the tumor in the optic channel. Large defect with absence of very thin bone, and we use also in case there are turbinates already resected in previous surgery, as you can see. And as you can see, this schema the technique to prepare the nasal septum flap. This is a large case of craniopharyngiomas treated with endoscopic endonasal approach. And I would like to show you only the closure, sorry. We prepare the pedicle flap. And we put finally, sorry, we had some problem for the clip. And we put finally the pedicle flap of the nasal septum. As you can see, we preserve also the middle turbinate and the ethmoidal box. It's a really minimally invasive surgery in this case. And this was the results. As you can see, the fat intradurally, extradurally, and the tumor removal. And this is the control after 3 years. In case of failure, you have to prepare to perform a revision. This was a case operated in another department. We are lucky. And you can see also the displacement of the fat in the ventricle system. You have to remove all the previous closure. We're looking for, and we remove the mucoperiosteum of the nasal fossa inferiorly to the inferior turbinate, and we use this pedicle flap to put in front of the closure to try to close. The results was very effective, but don't forget when you plan your extended approach, don't use all the tissue in the nose. Thinking always in case of your failure, because you need a vascular flap contralaterally. Don't use both if not necessary. In the clivus, this is another case of pediatric intradural scordomas. We skip to the closure, same technique, multi-layer, gasket seal, piece of bone to control the pressure, fat, and finally, obviously, the pedicle flap. And this was the results. And this is after 40 days postoperatively. We also control an extended
sorry,
approach
Diego.
Okay, we skip.
I'm very sorry. Yeah, if it's possible, because we have 2 more presentations, and it would be nice to have also discussion around at the end. Thank you.
Okay, thank you so much. I finished.
Okay, thank you very much. Impressive cases. We can come up later to the discussion round, and there was a question in the Q&A box which we can answer maybe at the end. So I would like to proceed to Marian Neidert, who is going to present us also some approaches for cranioduroplasty. Please, Marian. That was your presentation. Thank you. You have to unmute yourself.
First, thank you for inviting me, and thanks to the organizers for this fantastic webinar, and also to the sponsor. And these are my disclosures. None of them are actually relevant for this talk. This is the outline for today. So first, I will start a little bit about CSF leaks and pseudomeningocele, but I will be very brief since the previous talks also cover the topic. And mostly I will also talk about protecting the dura mater, so actually avoiding CSF leaks. So that's actually the best technique to deal with that topic. And then also about very standard dural closure techniques, and in the end, a little bit of literature and one exemplary case. So CSF leaks are not that rare, and in just covering the topic of cranial neurosurgery, the main risk factors are complex skull base, as we saw also before, especially endoscopic cases and posterior fossa cases, much less frequent in convexity surgery. And if it appears in convexity surgery, there's always the suspicion that there might be underlying conditions like hydrocephalus, which are the true causes for CSF leaks or pseudomeningoceles. Of course, the consequences if CSF leakage occurs are very relevant, so even potentially life-threatening. So meningitis requiring antibiotic treatment, require interventions like lumbar drains, resurgery, or also prolonging the hospital stay. And as also mentioned before, the costs are quite impressive. So the calculation is that one CSF leak costs around 10 to 15,000 US dollars. Of course, that's dependent on the country and on the healthcare system locally, but for sure it's a relevant factor. So pseudomeningoceles, they have been shown also in previous presentations, and then in German there's this nice word which is Liquorkissen, which kind of means a pillow made out of CSF, which sounds very comfy and nice, but in some of the cases it's not so nice because it can create problems, especially also cosmetic problems, but also the complications I mentioned before. So we really want to avoid that in cranial surgery. And the most important thing is, and that might be very basic now and also a little bit of trivial, but these are illustrations from the craniotomy book, which I can highly recommend by Professor Rabe, showing classical opening techniques, and especially also before and during craniotomy, it's important to protect the integrity of the dura mater. And this old saying, when you do the opening, think about the closure, is really important. So a very meticulous and proper detachment of the dura is a very high functioning technique in preventing CSF leaks during or dura tears, first of all, during craniotomy. It costs a little of time, but it's a very well invested time. Some people even go, if there's some resistance in advancing the craniotome, in with small dissectors and detach the dura along the craniotomy line. We don't routinely do that. We do detachments from the burr hole routinely, but not necessarily during the craniotomy line, but it's also an interesting technique and a possibility. And important during craniotomy is really how you handle the craniotome. So it should never be forced. So a lot of force is usually not a good sign. It usually means that there is some tilting or a wrong direction or turning of the craniotome. So if the craniotome is not tilted forward and not pushed with a lot of force, the chances of having a dura tear during craniotomy, of course, is much lower. So it's very basic, but these very simple and basic techniques can avoid severe and really meaningful problems. Also, when you have resistance during craniotomy, it's usually possible to inspect the integrity of the dura mater. So by positioning the light in the right angle and also going with a small suction, you can see whether the dura is still intact or not within the craniotomy line. And if that's not the case, it's usually not advisable at this stage or at this position to advance the craniotome further, because then you will for sure tear the dura over a longer period or a longer line or a longer length of the dura mater. So the idea would then be to change directions, to come from the other direction, or maybe even place an additional burr hole to avoid a large tear of the dura. So dura closure, Harvey Cushing was mentioned before. There's also an illustration that he did in 1909 showing his dura closure technique. It's not so much different from what we do today. So really the main goal is to have a primary adaptation of the dura and primary closure of the dura with sutures. We don't use the tourniquet anymore. It's luckily not necessary anymore. But the question was raised in the previous presentation already. When do we really need a watertight closure, and when might a closure that is just an approximation or bringing the dual edges together sufficient? And our philosophy here is that we really do watertight closures in these high-risk cases, so posterior fossa for sure, and also when there are openings of the air spaces. In the convexity, it might be okay to approximate the dura, and it doesn't necessarily have to be completely watertight. And maybe also one comment in a dura that is not closed entirely and has maybe even a hole is usually better if the dura closure is almost perfect. That's really probably the worst, because then when you have increased pressure during coughing or sneezing, then CSF is pushed out, but it doesn't get back in. So you have really this valve effect. That's when you have an almost watertight dural closure. So that's really what we want to avoid. So our technique, when we are not able to close the dura with primary stitching, so running or interrupted stitches, we, for example, would have holes. Then we really use autologous material to cover these holes. So that's either fat or muscle, and usually also positioned with sutures. And if there are larger defects, again, also our main material of choice to cover larger defects, also gallia or fascia lata, and not available in xenografts like Duragen or Neuropatch. Check-up sutures we really use only for cases, for example, epidural hematoma, or if you have a very large bone flaps, but it's not really a routine technique anymore, since the bone flaps, the craniotomies have become so much smaller, and there's really no need for that in our opinion. So the question is relevant whether it is necessary if you have a primary suture closure, and if you should augment that closure with an additional maybe sealant or any additional material. There is a little bit of literature also on that topic. So this is a study that my colleague Martin Stielen performed in cranial cases, where he looked at patients in a retrospective analysis that had primary craniotomy. So redo surgeries were excluded. Also spinal, pediatric, and posterior fossa, these high-risk cases, they were excluded. And he compared those cases where primary closure without any additional sealant was performed versus those where fibrin sealant, collagen-bound fibrin sealant, Tahosil was used. And he basically did not see any striking advantage at augmenting the primary closure with Tahosil. That also was evident in a multi-factor analysis, where also the most significant signal was detected. Of course, that's retrospective data, but there's also a trial on the way, which is called the NCASE-2 trial, which is a two-arm multi-center trial that really looks at a other xenograft, which is called LipoSeal, and this is meant also to augment the primary closure. And this study looks at a composite primary endpoint at 19 days, so wound infections, intraoperative CSF leak after applying the graft, and also during a Valsalva maneuver or elevation of the PEEP, and also percutaneous CSF leakage, the occurrence of pseudomeningoseals, pseudomeningoseals on imaging above 20 cc's. So this data is not available yet, but it certainly will be interesting to see what this study shows. So maybe how do we manage pseudomeningoseals? If we see that in our outpatient clinic, one strategy is certainly watch and wait. A lot of them might basically heal on their own, especially the ones on the convexity. Other techniques are puncture, then maybe in combination with compression dressing, lumbar drainage, and surgical revision. And I highlighted those, or I put those in bold where I think, or where we think in our department that are the most maybe helpful ones. So these puncturing pseudomeningeal seals and compression dressings, and also lumbar drains, especially if it occurs after a longer period of time, is often not very helpful. And as mentioned, also the lumbar drain is really linked to a lot of complications that are sometimes even life-threatening. So it's really something that we do very, very rarely nowadays, but certainly watch and wait. And if an intervention for whatever reason is necessary, then a surgical revision is usually what we would do. I'll show you one exemplary case. This is a 60-year-old male where I removed a grade 1 meningioma that has transosseous growth, and this patient was not so much bothered by the bump. A procedure like leg weakness.
Marian, there's a problem with your audio, I think.
Do you hear me now?
Yes, now it's better. Thank you.
All right. So this is a patient with a transosseous growing meningioma. We took out the tumor and then even had to also take out the bone. So we closed up this the dura with Duragen and then Palacos flaps, and then this patient came back to the hospital 3 months later and had this huge pseudomeningeal seal, and that was even growing over time. And we tried all the mentioned techniques except for the lumbar drain. So we did a lot of watch and wait, and it didn't really recover on its own. We even once punctured it and used a compression stocking, which as maybe expected, didn't really help much. So we had to do a surgical revision on this case and closed up the dural defect with fascia lata and with a fibrin seal, and put back the Palacos and removed a little bit of the skin, which was largely expanded by the pseudomeningeal seal. So in this case, surgical revision was necessary, but in a lot of cases also resolve on their own with watch and wait. So from my side, the take-home messages are really dural closure might be something very basic and trivial. It's a very small thing, but that leads to potentially very large complications if not done meticulously and in proper technique. One thing that is important is not just knowing how to treat dura tears, but also primarily try to avoid them with the techniques that I mentioned. Watertight sutures are very important in those high-risk surgeries, the skull base or posterior fossa, and whether it is helpful to add graft to a primary dura closure. This data is not available, but will be available hopefully in the coming years. Thank you for your attention, and I guess questions are later.
Thank you very much, Marian. And I would like to ask the last presenter, Niklaus Kugel, to show us in another anatomical area in the spine how to deal with dural closure. Please, Niklaus, the stage is yours.
Thank you, everybody. Thanks for inviting me. Hang on, I'm just going to close that. Perfect. I'm currently working as a spine fellow in Vancouver, and I have the pleasure to present to you and give you some insights on the treatment of how to treat dural closure and CSF leak in the spine. Now, generally speaking, we have to differentiate between an incidental durotomy and a planned dural opening. Although the right picture doesn't look nice, but that's just because in a melanocytic tumor, it is not always as controlled as on the right, rather seen on the left. I won't touch base on the anatomical part, but just want to let you know that like the inner leaf of the dura mater continues as the dura we know in the spine. We have the CSF running underneath the arytenoid membrane, and then this is usually a contained compartment until we either sustain a trauma, have a more or less successful spine surgery, or even have a spontaneous CSF leak, which may take quite a while to work up. Females are usually more prone to that in the age between 30 and 50, and it happens in the thoracic spine. That was a case we had the other day with this little spur, which made its way through the dura. The presentation is well known. You've got orthostatic symptoms. We actually had a patient recently with a CN6 palsy, just due to the chronic hypotension in severe cases, and that's what we've been talking about, which we want to prevent, is kind of the fistula, therefore making the patient prone for infection and meningitis. You always have to keep in mind, if you do a surgery, that you may have an entrapment of the nerve rootlet, and that may cause either neuropathic pain or any new sensory-motor deficits. And in severe cases, patients can develop a sepsis, or as shown in the literature, subdural hematomas. Now, the risk factors in the spine is similar to the cranial cases. Age is definitely a factor, smoking, diabetes, obesity, all factors kind of also distributing and contributing to degenerative changes. Connective tissues disorders have to be kept in mind, as the quality and the texture is not as well. Now, the lumbar spine is more prone to a CSF leak than, for example, the cervical spine. Degenerative cases is also a risk factor, especially if you operate on a synovial cyst. You miss this nice layer and plane you can work on. OPLL, definitely in the cervical spine, especially coming from anterior, but I'll touch base on that a little bit later. A previous surgery, as mentioned before by my colleagues, is definitely a risk factor for the same reasons with the synovial cyst. It adds up with the levels you decompress and also with the complexity. Now, obviously, when you start, you have kind of this helping hand that steps in whenever you need to, when it ever needs to do so. Once you get more experienced, you kind of maybe slow down. You then have a process where you think, oh, I'm super confident. You speed up again and you run into troubles again. And then you kind of face new challenges and you kind of drop with your ID rate again. So there is definitely a certain band that's following us throughout our surgical career. And also the fact that if we do an acute case, mostly like later in the afternoon or evening or even night, that is definitely a risk factor for it. Now, an incidental durotomy has a huge spectrum. It can range from the arachnoid bleb seen at A to a small pinhole or a larger defect, or even any like rootlet party that's popping out. So keeping that in mind, it is definitely a stressor because you don't know what you're dealing with, the shape, the degree. Usually you need to slow down, just get your pulse, blood pressure down, such as the Navy SEALs do, especially those who just like starting with neurosurgery. Take a break and just calm down. It just makes your hand less shaky and easier to close. The location might be challenging. So we had the other day like a intradural disc herniation, and like coming from transdural and opening up in a controlled fashion definitely help with the closure. So keep that in mind, and then also respect it for your closing technique. If you're unlucky, your patient is 87 or something and has poor like a dura texture, you may just want to use a patch or some fibrin glue to close it, as you may struggle and fail using a needle to adapt. Now, what are the so-called 10 steps? I added some more, but stop the CSF leak initially. You may do so using either a gel foam, a patty strip, and obviously let the team know. Get the scrub nurse, the instruments if you don't have them ready yet. Drape the microscope if you're an orthopedic, and using loops. Use binetted instruments. Get a suction tip that is smaller, and you can fine tune it using a valve and some adhesives and a suture to close. Change the table position. I think this is sometimes key. It obviously depends on the surgical technique you're using. It's not always possible, but make it kind of the highest point so the CSF leak resolves at some point. expose the dural defect. I think this is kind of the key step of being able to close it. So the most important thing is exposure, exposure, exposure. If you start off with endoscopic, you may not even notice that you have a CSF leak because everything is clear fluid around you, but I'll comment on that a bit later. If you use MIS working across L4-5 and you injure the L5 nerve root on the opposite side, may as well open it up, do a bilateral laminotomy and control it doing so. Or yeah, that is kind of a change to a laminectomy. You doesn't always need that drastic of a move, but if you do a laminectomy per se, the closure is definitely easier. In case of a trauma, please kind of have a look if you see any intradural hematoma or fragment. I think that is key, not to leave any residual in there. And if you see any fiber disconnection or transection, you may use a small proline to a monofil suture to readapt, but that really only makes sense if it's a single rootlet or so. Otherwise, it can get messy. Reposition the nerve fibers. You can use either a gel foam to kind of push it in. Use Penfield, some bionetted pickups to remain as adramatic as possible. If you have the issue of like a ventral tear, just really make sure you have a nice plane and you don't entrap the nerve root somewhere. Coming back kind of to the cranial cases, consider doing a sandwich technique. So if the defect is large enough, use the CSF kind of as your tool and as your help to prevent any further CSF leak. That just prevents any dislocation of the nerve rootlets. If the anesthetist is kind, the patient won't wake up and you have this little whale blowhole and the rootlets stick out again. So that definitely helps. And the dural repair, I think, is key. There's good data that if you can repair it directly, you should do so. Whether it is interrupted, that is kind of a personal preference, but if it's a longer defect, definitely use running, but interlock it intermittently. If it's more on the lateral or hard to reach, you may use clips. Now you can see that's kind of an anterior hole there. They did a nice transdural repair of the front, closed it directly, and then took care of the posterior part. As an add-on, keep in mind you want to keep the soft tissue on the dead space as small as possible. So get the fat tissue and muscle in, or think about a dural graft if possible. Augment that with an outside patch and keep some pressure on so it really sticks nicely. An epidural fibrin glue is definitely an add-on, and it shows that the pressure the CSF has to overcome increases significantly if you can really seal those suturing holes off. A Valsalva maneuver has been mentioned. We usually do it if there's like no concern, if you're confident, or if you're critical. Now, if you see CSF coming out, there's no point of like doing a Valsalva maneuver and kind of worsen your whole situation. As I mentioned before, you use the stuff you have. The fascia was mentioned before is kind of the go-to strategy, but it is, as mentioned before, kind of associated with pain of the patient, discomfort. You may just use the multifidus, but keep in mind just kind of disconnect it to some extent. So when the patient is up and moving, it doesn't pull all the time. And then once you think about closing, I usually use a drain without suction though, like just use gravity to keep that dead space as confined and as small as possible. I usually use runnings and like interrupted sutures for the fascia, really anchor it back to the spinous process, keep it kind of compact, and then doing a running suture on top of things. I personally think, and I'll quickly mention that there is no need for bed rest in the so-called watertight closure cases. And a lumbar drain is something we do use as a bailout strategy. Over here in Canada, actually, they use a pump system because of teaching reasons, but that's a different thing. Now, that's, I think, a pretty good kind of paradigm on algorithm how to address it. If you have a CSF leak, try the primary suture first. Use a combination. It definitely increases your quality of closure. I do personally like to use a deep wound drain, and that can even stay in for a bit longer. you may use antibiotics for coverage, although there are contradictory data for that. If it's controlled, perfect. If not, think about adding a lumbar drain. You can do that depending on the case, either open or not. If it's L4-5, 5S1, definitely get it up a bit more cranial and make sure the drain kind of leaves in a separate fashion. If not, you may add that zone. So generally speaking about the risks of CSF, apparently endoscopic has a lower risk. However, if you use an interlaminar approach, that ratio goes up a bit higher. As I mentioned, it might be underreported just because of the fact that small pinholes or arachnoid blebs might not be apparent and the CSF might not be seen. And there's actually a discussion and a questionnaire that was answered, and more than 50% of the surgeons doing endoscopic surgery don't treat a small dural tear, as they kind of trust and have faith in the soft tissue covering the defect, as you have literally no dead space. In some cases, you might add like a muscle flap or just like a muscle piece and fat, inject some fibrin glue, as mentioned before. And there are single reports showing a direct repair, but that definitely needs a certain skill level and exposure. So therefore, I would recommend keep your conversion rate, or be generous and be open for an open treatment in case you have a nerve root entrapment, for sure. Now, ACDF, super low risk of CSF, but it can be troublesome, difficult to address. So if you don't do a corpectomy, you usually can't really close it directly. Use like a taco seal or whatever, like a different type of collagen fleece and fibrin glue to augment things. The OPLL definitely drives the risk up high. In A-leaf, D-leaf, O-leaf, the risk is really low. Usually it is more frequently seen if you have previous surgery, just because of the scar tissue. And if you crank it up, that may lead to a tear. Or if you run up too lateral and run into the root, there is similar as with the anterior approach, just get some compression and seal there. Also keep in mind, if you're working around the thoracolumbar junction, the whole CSF may drain into the thoracic cavity, so it might not be apparent to you. What do we have? We talked about it. We got muscle, we got periosteum, we've got fat, but the cadaver thing is kind of, due to BSE, that's kind of historic, but amniotic membrane is something that different disciplines look into. The benefit of it is not immunogenic, just because it doesn't have any MHC antigen presentation. And then, as pointed out by my previous speakers, my colleague, the pericardium, especially in pigs and horses, but also in bovine case, it might be kind of a xenograft you can use. They're usually good in terms of biocompatibility. You have low antigenicity, therefore. There are some samples you have kind of Duragen, tissue dump, taco seal, what have you. But just keep in mind, if you use like a sealant, this actually may clot and have some space occupying effect as well. So there are cases in the literature that actually show neurologic worsening after using that, just because it gets compressive. What about the bed rest? We actually did a study, first retrospective, then prospective. The durotomy rate of at our department was around 4.5%. And we had pretty much 100 patients. And despite like the data from the retrospective showed there's no real benefit of bed rest, therefore we quit. And you can see that by kind of a drop from 2/3 to 1/8. And despite that, our ID-related revision rate went down. So if you achieve a good closure, there's no need for that. You only end up with a longer hospital stay, higher costs, higher pulmonary complications, and you don't really see a change in the outcome or return to the OR rate. Now, what about the wound drain? I mentioned that don't use suction. It can be clamped if you are kind of worried about the output, or put a clamp and kind of regulate it. It kind of prevents that valve mechanism, that the pressure is building up and pushing against the neurologic structures. And there's actually been data showing that the longer the drain is in, the better it is for your wound to heal. That is a case I would strictly want to share. Also, that can happen. Patient I took back for hematoma, I put a drain in there, and the patient used a massage gun 2 days after surgery, and he actually managed to put his drain into the dura and it was on suction. So he literally suctioned out 100 cc within seconds. Luckily, he only had headache, but obviously this required kind of a revision and yeah, some teaching to the patient. The lumbar drain, the report reported success rate is relatively high, more so on the C-spine. The duration is somewhere between 3 and 5 days, and the recommended drainage rate is around between 120 and 240 cc over 24 hours. A shunt is kind of the last resort, so you may use a lumbar peritoneal shunt if everything else fails. Literature says that this can be removed once kind of the symptoms resolve. Dural repair, generally speaking about the outcome, there's a lower revision rate if you suture. If you augment it, even better. You obviously have a longer surgical time, so this will be part of your learning curve, knowing when to speed up and when to slow down. It is associated with a longer hospitalization. Apparently, according to literature, there is good outcome and rare sequelae. However, we definitely have data also showing that those patients have more pain, worse patient-reported outcomes, higher revision rate, and also, as previously presented, higher treatment costs. Just generally of note, like females definitely have a high tendency of intracranial hypotension symptoms. Last quick case, deformity secondary to a neuroblastoma that was treated in the past. Patient presented again with a myelopathy, had this little spur there. You can see it kind of poking towards the myelin, overall little coverage above the hardware. So the decision was made to go in and decompress. Obviously, they had an anterior CSF leak, otherwise I wouldn't be presenting. They tried to treat it with a hemopatch and TCL. Unfortunately, it failed. Despite putting a lumbar drain and reintroducing a lumbar drain after it got dislocated by the patient. Furthermore, the skin eroded. The superficial rod actually made its way through the skin due to the bed rest that the patient was on. So plastics was involved, got a latissimus advancement flap, added hemopatch to seal one suture, and the lumbar drain failed again. That's the beautiful flap and the pseudomeningocele. So the decision was made to go in again, have plastic as kind of a backup there. And we actually ended up doing a dural repair, which in that case, luckily worked out. So always try to get another arrow in your quiver so you can deal with these complications. They might be minor, but they can have catastrophic consequences. Thank you so much for your attention.
Thank you, Nico. Thank you to all the presenters. Unfortunately, the first two presenters had to leave us, but maybe the roundtable participants and also the other two presenters can answer the questions. Unfortunately, we have proceeded a lot with the time, so I would like to ask the three first questions and to kind of combine one of them. So the first question from the audience was, how does the free flap at the end remain in position? Probably it's regarding the endoscopic transnasal approach. Maybe Marian, Thomas, or Malte can answer this question.
I can.
Feel free.
We rarely use a free flap. It's usually in our practice pedicle. But if it's a free flap, we would place some Fibriseal on the edges and some fibrin glue.
Yes, I think additional support is always good for your duroplasty, either in cranial or in spinal surgery. So next question was from Ahmed Karagos. He wanted to ask whether it's necessary to repair anterior durotomies of spinal dura mater. Nico, maybe you can comment on this. I think the last case was very kind of striking example. What happens if you don't do it? Sorry, you have to unmute yourself.
Sorry. I think like you have to repair it just to avoid any like fistula. I think a pseudomeningocele can be kind of lived with. That's something it's up to debate. You may just aspirate it, but as soon as the skin is kind of perforated, that definitely needs advancement. And feel free to get plastics involved. Get a latissimus flap or a trapezius flap to get the best closure possible.
And one more question to you from Jitendra Thakur. He was a fellow in our clinics quite a long time ago, but yeah, he asked whether in spinal duroplasty you have observed that the MEP signal can drop down. This is something that he has observed in burn. So do you have any experience with this, Nico?
I mean, there's obviously the one thing is like the duroplasty for cases in the trauma, like spinal cord injury. That's something we're looking at right now. But generally speaking, I have not experienced it. You just got to make sure, especially in the thoracic spine, that you don't compress it too much and you kind of strangle the myelin. That's probably the key thing.
Yeah, we have to always be cautious about the amount of fibrin glue or any kind of tissue that you put down in your duroplasty in order to prevent any kind of neurocompression afterwards. Okay, so one more question about lumbar drains. What level do you use? Reference possible, and what drainage volume do you permit? Maybe to all of you. What is your experience or what is your practice?
Like honestly, for me, like the lumbar drain is the last resort. If I notice that I can't achieve a good closure either in cranial cases or lumbar or like spine cases, I would add that obviously in the lumbar somewhere L4 or so. If I have an L4-5 pathology, I'd rather go higher and place it more cranial. And the drain rate is really up to the patient. I do tolerate a little bit of headache because I want to keep it as high as possible. But I would roughly start with 5 cc over per hour and see how he or she tolerates.
And almost same question, but about the lumbar drainage. When do you consider that it failed? How many days would you put it inside? And do you give any antibiotics when you place a lumbar drain during this time?
Over here, they have like the general application of NSAID, like cefazolin, for like 3 courses. I usually discontinue it. If I put it in secondarily, I do edit, and if it's like a drain that's in for more than 5 days, I would also use antibiotics, although there's no good data, and actually data showing you kind of just create resistance either, but yeah.
Okay,
yeah,
so
we wouldn't put antibiotics either, but I think it's important to also control your CSF on a regular basis afterwards. So you don't just put it in and leave it, but also test the CSF, especially to detect potential meningitis early.
yeah, very nice comment. I think it was a fantastic webinar. We had really great talks, very nice cases, and I thank all the participants. We had more than 120 participants at some point, and to all the presenters for the time spent. And thank you very much, and have a nice evening, and see you soon. Thank you. Bye-bye.
Bye-bye.